dentistry is the only branch of medicine that leaves a dead tissue in a human being and calls it a success. That was a thorn for me. I couldn't get that out of my brain. And it's true. And that's not every root canal, no matter what the reason that had to be done. They remove those things. So they remove the nerve, the blood supply, lymphatic system. The immune system obviously resides in there as well. They remove that and they seal it and fill it up. And it's not like anyone's out to do a bad root canal. But the anatomy of the inside of a tooth makes that process very difficult. So depending on the literature that you read, the inside of a tooth is extremely porous. It's like this massive sponge. And there's these little things called dentinal tubules. There's a lot of space, a lot of sponge space. And so we leave behind bacteria is what I'm getting at. And when we leave behind bacteria and they're inside these tubules, it's very small and it's too big for the immune system to get in. Macrophages, neutrophils, all these things. So you create an anaerobic environment for pathogens that live. Their pathogen is one thing, their toxins, their biotoxins in a sense are another. And we trap that in there and we can cover it up. We can make it look pretty. We can put a nice cap on top or whatever that looks like. But we leave that dead tissue in there.
Hello, and welcome back to another episode of the Smarter, Not Harder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Scher. It is a pleasure to be with all of you. I have so much fun recording these podcasts. It's almost not fair, I'm going to say. And today was one of those days where, again, it just represented itself with a fantastic guest. His name is Cody Kriegel, and Cody is a friend. I've met him over the last couple of years. He's a biological dentist, and we talked all about biological dentistry in this episode. So here's a bit of a bio on Cody. So what does Cody do? He is a member and fellow of the International Congress of Oral Implantologists, the Institute of Biological Dentistry and Biodentistry, fellow and accredited member of the International Academy of Oral Medicine and Toxicology, IAOMT, which we talk about during this podcast. He's an international lecturer and expert in ceramic implantology, a member of the Academy of General Dentistry, and co-chair of the Jawbone Pathology Committee. That's also part of the toxicology committee that he's involved with. So he graduated from University of Iowa College of Dentistry. He just opened a new clinic in Iowa with his wife, who's kind of his right-hand lady that does all the amazing things on the backside of the practice and doing amazing work. And this new clinic they just opened is called Vios Dental. They have a new hyperbaric chamber in there, which is super cool as well. And so I've been working with Cody because he reached out a couple of years ago now, maybe about a year and a half ago, about bringing in hyperbaric therapy to his office. And we just hit it off is what I can say here. And he is just phenomenally smart when it comes to biological dentistry. So I wanted to bring him on to talk about a couple of things. So what is biological dentistry? Exactly. What makes it different from regular dentistry? And we talk about that in detail. We talk about Cody's story on how he got involved or interested in biological dentistry through his mom and some of the work that she had done actually on root canals. And so then we spoke in detail about root canals, what's wrong with root canals, why they can cause issues, how they could be more systemically operating in the sense of systemic symptoms, and you get rid of the root canals and things get better. We discussed his ways of operating from a preoperative, perioperative, and a postoperative perspective using IVs and ozone and something called PRF, which is platelet-rich plasma, basically, and then some albumin kinds of things from other areas of the stuff that you spin out in the ways that you're doing things in this practice, which is super cool. And I learned a lot about that this time. We spoke about mercury and metals in the mouth, other types of implants as well, not ceramic, but the titanium implants as well. And so we talked about safe ways of getting mercury out of the mouth and why it's so important. And some of the studies that were done back in the 80s that showed that mercury was dangerous. And of course, we didn't listen to it at the time, and people were continuing to get amalgam fillings. We additionally talked about other more safe types of fillings that he uses in clinical practice and why they're so important. Then we transitioned to talk about cavitations and wisdom teeth and how wisdom teeth are being taken out oftentimes now because our mouths are getting crowded and we don't eat the types of foods that we used to eat, and we don't have room anymore for these wisdom teeth. And then when you take them out or take out any tooth, you can leave these cavitations, which are actually in the bone itself and can cause significant inflammation and chronic fatigue and gut issues and sleep issues. And he talked about various stories about patients that he's worked with that have had these issues and then you resolve the cavitations and they get better, shockingly. And so from there, we actually spoke about children and how to optimize a mouth of a child in the sense of not taking out teeth, but optimizing and expanding the jaw is what he really discussed in detail here. And he has some colleagues that work in that capacity. And finally, we wrapped up the conversation talking about oral hygiene. Fluoride, good or bad, mouthwash, the oral microbiome, flossing, tongue scraping, the types of ingredients in toothpaste that you should be avoiding and kind of looking forward to using instead, and more. This is a fantastic conversation. I had such a good time speaking to Cody. I really hope you guys all enjoy as well. If you do, don't forget to like and subscribe below so you never miss an episode of the Smarter Not Harder podcast. And without further ado, here's Dr. Cody Kriegel. All right. Hello, Cody. How are you today, man?
I'm good, Scott. How are you?
It's great to see you. It's great to have you on the Smarter Not Harder podcast. I've been excited for this opportunity because, look, I think biological dentistry is awesome, and there aren't that many of you guys and gals in the world that are doing it. And so there are a lot of clinicians that listen to this podcast, and understanding what you guys do, how you do it, what's different from regular dentistry, how you got involved in all of this, and sort of giving the context it's going to be awesome. So thanks for being here, man.
Yeah, man. Anytime to spend time with you is good time.
Well, I'm excited. So I think the first thing we can do is let's start off with some definitions, because that's a good place to start. Let's discuss what is biological dentistry as you define it, Cody, and what makes it different from, let's call it kind of classical regular dentistry. I think that's an easy first question.
Sure. Yeah, I mean, biological dentistry isn't really an official, subset of dentistry per se, although I feel strongly it should be, of course,
sure,
in my bias. But it really is an overarching kind of theme in dentistry where dentists take a really good look into how kind of the oral systemic connection, how the mouth connects to the rest of the body and kind of vice versa as well. I think traditional dentistry, the way we are trained, takes a really mechanical kind of construction basis approach of fixing a tooth or fixing a few teeth. But we forget maybe the concept of like, hey, this is a human being. What we do has an impact beyond just that one tooth. And so it's a really kind of focus on an integrative connection between the mouth and the rest of the body.
And so how did you decide this is where you wanted to go, man? Because I'm obviously in dental school, you're not learning anything but like sort of mechanical procedures as you just described it. It's more of like, this is a tooth, I'm going to fix it, I'm going to do this to it, I'm going to drill it, I'm going to take it out, I'm going to crack it, whatever it might be. I've had, these things just give the chills to me still. As a kid, my father, who's a chiropractor, as I think he refused to let me get any anesthesia at all, even including Novocaine or anything like that, until I was like maybe 10 or 12 years old. So I had some pretty bad experiences at the dentist when I was young.
Yeah, totally.
I didn't do a very good job brushing my teeth. But anyway, so I wonder what your experience was, or how did you get involved in like just reorienting your framework?
Yeah. The mechanical approach has to exist. We have to be trained in that. I kind of always joke that dentistry prepares us to get out into the world and know enough not to like kill someone. And then the real training happens, right? The real learning. And I think that goes with a lot of professions. But for me, I've always been interested in health, things like that. And I just learned real early on, I was introduced to, some of these approaches in biological dentistry, particularly from Switzerland and Germany and some of these places, and kind of where it goes back to. It was really attractive to me. It helped me bridge kind of my personal passions of health and wellness with my profession, which was dentistry. And it was a whole new world to learn and train in, and a lot of things I had to kind of set at the front door and forget. I was almost like a retraining process. And as I started to study the research myself, I'm a big fan of, I don't like to just blindly ingest what I'm told. I want to take a look at all the cards, study things, read research, and then make decisions that I think are appropriate. And then I had an experience with my mom. Her health dramatically changed after some treatment that a mentor of mine, we'd kind of treated together. And once it changed, I couldn't unsee what I saw. And that had a really personal impact on me because it was my mom. I'm very close with my mother. And from that point on, it was kind of like one of those things where I felt God was saying, hey, you got to go and do this thing. This is what I have for you. And so when I do things, it's kind of 0 to 100. And I pick up the pieces, behind me sometimes as I go. And we just kind of dove straight in.
Yeah, I mean, I think that's a fantastic way to. I love that story. I mean, the pioneers in fields intend to be more of the 0 to 100 type in general, right? They're not the people that are just going to kind of tiptoe in and kind of like, oh, maybe I'll do like that, maybe I'll do this. I get that sense from you and a
Yeah.
lot of the biological dentists that I've spoken to, because you're pioneering a new field. There's not that many of you. I mean, how big of a group of biological dentists at this point are there around the world? Do you have a sense of that?
Oh man, I would argue, and I don't know this to be true, but I would argue that it's more of an approach that you see in Europe and some of those places. It's more accepted, I would
Mhm.
say. In the U.S., maybe not as much, at least to the extent of its full capacity. But I agree. I think a lot of dentists that I see, they understand maybe some of the lower concepts or some of the more fundamental things,
Sure.
but then taking it to the nth degree is kind of, I think, I don't want to say saved for a few, but only a few of us, I think, will go kind of full in, and that's good. I mean, everyone starts at their own spots. There's stepping stones along the way, absolutely. But I think to its fullest extent, there's really not that many. But I agree with you. We are in the. I think we're all a bunch of mavericks in a sense. We've
Yeah.
pioneered it. We have the research. We're seeing the things happen in real time, and I think it's on us to produce more good peer-reviewed literature to support. Hey, this is what we're seeing, and this is why it's happening.
Yeah.
Um, and
I
that
love
stuff,
it.
it takes time. It takes time.
No, I love it. I think any new field takes time. I mean, I've been involved in, as you know, hyperbaric medicine for many, many years. And
Mm.
like, if anything has taken a lot of time, it's hyperbaric medicine. It's been around for
Yes.
400 or 500 years or something
Yeah,
like
like
that. And
centuries of
yeah,
time.
yeah,
Yeah.
yeah. That's been around a lot. So it could take a while. Like everything's got its, hopefully you guys go a little bit faster than hyperbaric
Yeah.
medicine overall. And I think you will, with all the tools and tricks and technologies and things. And I love the idea that, it's more of a holistic perspective, right? Like my perspective is so much more holistic, obviously, than just looking at cellular health or looking at a hyperbaric chamber or, one particular marker. I think one of the main places I know that you do a lot of work, and I thought we could start off as a biological dentist, would be root canals. So
Ah,
many of us have them, including maybe somebody on this phone. It's not likely going to be you,
yeah,
given your perspective. So tell me about why people get root canals, what's wrong with root canals, and what do you think, what are the perspectives that you use in clinical practice and how to address them overall?
sure. Yeah, so I think the first one on this is a hot button topic.
Yeah.
I think the first thing to say is I never like to live in absolutes. So I don't think that everyone out there that has a root canal is going to die tomorrow,
Okay. That's
just
good
like
news.
anything else. So let's
Good.
let's
Yeah.
set that stage
Good
straight.
news.
But
Okay. I'm okay for a couple more days. Okay.
yeah, you'll be here. You'll
Okay.
make
All
it
right.
to the end of the podcast, hopefully.
Okay. Cool.
I
All right.
think
We're working on it. Yeah.
usually I start this conversation off by kind of going back to where we started the podcast, which is some definitions. So I think the definition of a tooth needs to kind of be constructed. This is the way that I learned early on, and I had to. Again, I knew what a root canal was. I was trained, and in fact, I did multiple of them to get out of university.
Sure.
We have to. So um, a definition, I think, that is what is a tooth in a sense, right? We think it's an
Okay.
innocuous, benign thing in the mouth. We use it for chewing, and it can hurt, flare off, and be super painful. We get things worked on, whatever. But if you take a tooth and take a step back, and the logical brain, logical side of your brain starts to kick in, it's actually an organ by definition. It has multiple tissues: enamel, dentin, cementum. On the inside of the tooth, there is a nerve. Technically, it's an extension. It's the terminus or the end of the trigeminal nerve,
Okay.
brainstem, cranial nerve, right? Cranial nerve 5. And in that, there's the nerve, right? There's the blood supply. There's a lymphatic system, connective tissue, all that fun stuff. So inside of a tooth exists the things that would make up, any other organ.
Got it.
And I think what rung true to me early on was dentistry is the only branch of medicine that leaves a dead tissue in a human being and calls it a success. And that was a thorn for me. I couldn't get that out of my brain. And it's true. And that's not every root canal, no matter what the reason that had to be done. They remove those things. So they remove the nerve, the blood supply, lymphatic system. The immune system obviously resides in there as well. They remove that and they seal it and fill it up. And it's not like anyone's out to do a bad root canal. But the anatomy of the inside of a tooth makes that process very difficult. So depending on the literature that you read, the inside of a tooth is extremely porous. It's like this massive sponge. And there's these little things called dentinal tubules that are
Okay.
usually like a couple microns wide. They're very small.
Mhm.
And roughly speaking, depending on where you're at, the location in the tooth, there can be anywhere from 50 to 70,000 of those per square millimeter. So
Okay.
there's a lot of space, a lot of sponge space. And so we leave behind bacteria is what I'm getting at. And when we leave behind bacteria and they're inside these tubules, it's very small and it's too big for the immune system to get in, macrophages, neutrophils, all these things. So you create an anaerobic environment for pathogens that live. Their pathogen is one thing, their toxins, their biotoxins in a sense are another. And we trap that in there and we can cover it up. We can make it look pretty. We can put a nice cap on top or whatever that looks like. But we leave that dead tissue in there. And with the advent of CBCT, 3D imaging that I feel like is a standard of care.
That's cone beam
computed topography. Yep. So when we take 3D scans of root canals, we will routinely see that they'll have an infection with them. And I think the scary part about root canals is that since there's no nerve, typically there's no pain.
Right.
So there's no symptoms to alert you. And the literature is very forward in when you see those infections, like that can have a systemic impact. Whether it's cardiovascular, whether it's metabolic, it can have a lot of pro-inflammatory issues that can be kind of dripping. I usually look at it as into the patient's system.
Yeah. Pardon the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training practitioners how to optimize health rather than treat disease. For this episode, check out our Exposomics module. This is our module of the toxins in our environment, which include toxins in our mouth, including mercury, amalgam fillings, and other things just like this. So check it out at homehope.org. If you're a clinician, you can learn how to optimize the exposomics aspect of your patient and client's ecosystem, their holobiont, which is something we also discuss at Health Optimization Medicine and Practice. Go to homehope.org and save 10% on this module by using code podcast10 at checkout. Now back to the show. What do you typically see? So does it depend on where the root canal is that will be more associated with various more systemic issues, or could it be any systemic issue with any location of the tooth typically?
That's a super good question. Yeah. So I think to set the record out, I think anybody that has a root canal, you need to be looking at those routinely with 3D and keep them assessed. People tolerate them differently for sure.
Yeah.
I think the record I have is I think I had a patient with 5 or maybe 6, one patient that were reinfected and they had no idea. And that's a problem for their systemic health. So to answer your next question, that's a really good question. That's based on what we call EAV or electroacupuncture according to Vol. So what that is it's kind of the meridians. So meridians are based on acupuncture.
Acupuncture meridians,
most established forms of medicine, right?
Yeah.
And basically, a long time ago, I'll say that, they showed that those meridians run through your teeth. And so your teeth were sitting on areas that kind of run to other areas of your body. So I don't diagnose with the meridian system. We have a huge one in all of our treatment rooms.
Oh, really?
We use it as a self-diagnostic tool to just make patients aware of it. But
nice.
I will say that I routinely see that playing out pretty accurately. And that's what my mom, that was her story.
Oh, interesting.
And so at first glance, you look at it as this can't be, this is silly, this is wackadoodle. But I remember first hearing about it. I remember Thomas Rao, an integrative oncologist, mentioning breast cancer and root canals on a documentary, right? And so at that point, I was really just tipping the toe into this, and I thought that seems like crazy. There's no way.
Sure.
But anecdotally speaking, from my experience, when I went into my clinic after that, I had 6 women that I knew at least had reported breast cancer or a history of breast cancer on their health histories. 5 of them had a root canal on that meridian. And I'm not saying that their root canal caused their breast cancer, but that was my experience early on. And I decided that was enough for me to take another look at it. So I think it's interesting. And I think maybe it'd be great to study that a little bit more, but it's intriguing.
Yeah.
And
do you think one of the things, I know that, this is sort of a side question, but within it, it's we always are told, at least in medicine, in medical practice, I'm an internal medicine physician, that when you brush your teeth, you get mildly septic. You mildly bacteremic, excuse me. You don't get septic. You get mildly bacteremic.
Thank the Lord, no one would brush.
Yes. Septic is not the wrong word. Mildly bacteremic, which means that you get a certain bolus of bacteria that get into the circulation as a result of brushing your teeth. Do you feel is it more potentially prevalent to happen if you have these sort of areas that are like for example, in a dead tooth, in a root canal, that could potentially cause maybe more systemic issues as a result of that? Or do we feel it's more that there's a local inflammatory reaction that's just causing more of a systemic cascade as a result of that?
That's a good question. I think it could be both, depending on the patient. Okay. But you bring up a good point where I think where most dentists, or they all know that different governing bodies, it depends on who you listen to, whether it's orthopedics or cardiology, but basically there's the whole concept of pre-medication, right? Before it comes, some people still do it, some doctors still want it, some don't. So it's put dentists a little bit in the middle on like, hey, should we not? You refer to the doctor, but at the same time, there's the concept of pre-med, which is basically you're going to take an antibiotic before you even get your teeth cleaned in some people choose, right?
In some circumstances,
because there's a microbiome in your mouth, and you can that can get inside the system. If you floss and you bleed, and a lot of people have oral inflammation. Fireworks! There we go.
Nice.
People have oral inflammation. I mean, a lot of people do. Gingivitis, gum disease, those things. And when you get that bacteria inside the system very easily, routinely, all the time. But for some reason, we've left that mindset at the door when it comes with a root canal.
Okay.
And I think it's out of good intention. I mean, we don't want to go around and just start pulling people's teeth just for fun. But I do think that there has to be an informed consent discussion with the patient. I still have patients that choose root canals. Absolutely. We've talked both sides of that coin with them. And I say we're going to watch it for sure. But they need to know that there could be a systemic risk that could come with that.
Got it.
And so I think that's what dentistry should be doing. And I think that's what we need to do for our patients.
Yeah, that makes a whole lot of sense. So let's talk about what you would typically do. So first of all, a root canal basically is you're taking out the root of the tooth, right? Then you're taking out the whole tooth, or just maybe define exactly what a root canal is. Maybe for me, because other people probably know, but I forget. And then what are the alternatives in the sense, if you want to take somebody's root canal out, right? If you want to get rid of this potential abscess, this sort of pocket of infection, not always an abscess, of course. What are your procedures? What do you do? What's your procedure to do this typically?
Sure. Yep. So root canal, they go in and they will, a dentist, I feel root canal should usually be done by a specialist, an endodontist who always does root canals.
Right.
They have usually more specialized equipment to do a better job. And I will say we can do better root canals now than ever before. But I do think that because of the anatomy of the tooth, just because what it is, it's impossible. You can't sterilize it. It's impossible. So then what they do is they remove, it's almost like glorified pipe cleaners in a sense, where they go in, they will remove where that nerve is. So we call it the pulp, the nerve, blood supply, lymphatic system, connective tissue, all those things.
Got it. Okay.
When you do that, then if somebody's in pain, typically they'll be out of pain because you removed the end of that trigeminal nerve, which is it's also interesting to think of it that way.
Yeah.
Right? You literally clip the end of that nerve.
Yeah, it's like cauterizing the nerve, like almost. It's like
remove it all out of the tooth, and then they will clean it. There's a lot of different ways to clean it. There's a lot of different techniques that have gotten a lot better, by the way. And then they will seal it, usually with gutta percha and some sealers. There's some different things in those that I think sometimes you need to be aware of. But they seal that off, and then you have no pain, and you still have the tooth. When patients come into us, we always take a cone beam, standard of care, I believe. We watch those. If we see an issue with them, we have that discussion. Or if a patient chooses, hey, I know what a root canal is, I don't think it's a good choice for me, what are my options? The best option, in my opinion, depending on the patient and the case, is a replacement with a ceramic implant.
Okay.
I'm not a fan of metals at all in the mouth. For lots of reasons, we can talk through that. But the most biocompatible option would be a ceramic implant that kind of goes where that tooth was, and then we can put a ceramic top on that and done.
So if you're putting in just from a mechanical perspective, you've taken out all of the tooth, like the pulp and all the nerves and lymphatics and things like that. You've sealed it with a root canal. How does a ceramic tooth change the whole ecosystem? Are you taking out more? What are you doing exactly that the ceramic will do that the other procedure wouldn't as a root canal?
Sure. So root canal, when you remove the inside of the tooth, that's on the very kind of center of the tooth, but you would never notice as a layman, or because you still have the rest of the tooth. You still have the root, you still have the top of it. You kind of seal the little hole, and then it's done. When you do root canal removal, you're removing the whole tooth. So what you see in the mouth, and then the root that goes down inside the bone. So that goes to another point of teeth are really interesting. They span what I call from outside body, technically the gut tube, to inside body into your bone.
Yes.
And so dentistry, in my opinion, needs to take surgeries, whether it's a root canal removal or cavitations, whatever we're doing, much more serious. Like it's an orthopedic surgery. We're operating on a bone. So we need to be sterile. We need to be using appropriate materials. We need to be taking time to clean it really well. I mean, these are standard practices and in hospitals and surgeries.
Sure.
And if you had a dead piece of bone in your, they would remove it. That's not okay to leave.
No.
So I think we need to be taking that a little bit more serious. But you take out the entire tooth, all of the root, you clean it really well. We have a protocol that we follow very specifically for a surgery like that. And then the implant goes kind of where the root was. So the implant, you can think of it as a root replacement.
Got it. Okay.
And then you put a ceramic cap on top, and that's like your tooth replacement, what you see as the top of it above the gum. Yep.
Nice. Okay. And so let's talk a little bit about like that kind of, I know you have all these different things that you do. I mean, you don't have to go into like very minute details, but what are some of the things that you're doing to help protect the tooth or the area while you're doing the ceramic implant? Like I know you're using other kinds of procedures, like other therapies locally. What are you doing otherwise to help protect the area as you're doing it?
Yeah. Yeah. So the kind of the protocol that we follow is, and when we have a patient, typically if they're coming in, if they're doing one tooth, multiple teeth, if we're doing other types of bone surgeries, I always start with kind of, obviously we need a clean environment. So people need to have their teeth cleaned. But then I like preparing the train mentality. So we have whether we're doing IV drips, of course, I'm a huge fan of hyperbaric, thanks to you and training with you. So we're kind of preparing the train to go through a surgery is kind of how we look at it. In the surgery, we're using lots of pre, during, and post. We're using a lot of laser therapies, whether that's a laser through an IV, laser locally on the site, or a laser, a type of laser cleaning of the bone when we're and to stimulate some healing response. Lots of ozone is used. What's that?
What kind of lasers overall? Is it what like nanometer lasers are you like sort of lasers that are going directly here? You said like a laser in the IV as well. Like what kind of IV laser?
Yeah. So we use what's called a Weber med. There's different. Different wavelengths of light. So we use red, blue, green. Different colors will stimulate different cellular components in a sense. To do things, to help us heal, regenerate. I really like the idea that we are designed very well. I mean, like God made us well. Our body knows how to heal very well. We sometimes have to remove like what I call like the splinter or like the pebble in your shoe. You remove those things or what my good friend Dominic Nischwitz likes to call like interference fields. Remove those interfering with your optimal health, and your body knows what to do. And I think one of my favorite things that we use, and we're not the only ones, but is what's called PRF, where we'll take vials of blood from a patient. We will use a centrifuge at different speeds depending on what we're after. And we will take that out. We'll use the platelets, the growth factors, the stem cells we'll use from the patient to help with a healing response. And now we've been playing with heating that. So you can heat the albumin. That'll make it last longer. And you can combine it with other growth factors, and that will have a much more long-lasting kind of response. This field is changing quickly. I feel like if you don't keep up, you'll get left behind. So, but that plays into our hands from a biological perspective of trying to avoid using things that could stimulate an inflammatory response in a negative way that we don't want.
So the PRF, the ozone, this heating of the albumin, you said, is that albumin like you're actually getting like sort of separate albumin that you're using as well? Or is that part of the actual albumin of the blood supply, or what do you...
So we would take out a vial of blood, we'd spin it at a certain speed, you separate kind of the platelets from the blood, right? And then the top chunk is what we call the PPP, platelet poor plasma. So we can peel that off and heat it. And then that's
heating that. Okay.
And we heat that, and then we mix it back with the growth factor. So it's like a
interesting
factor impregnated albumin gel from the patient. Yeah, it's wild.
Interesting. I haven't heard of that before. And so then you're just injecting it with like, sort of microneedles around the area, or where are you putting it exactly?
Yeah. So a lot of this I've been learning with my really good friend, Rick Myron, who's kind of a staple in this field with PRF, arguably one of the best in the world. He's published a ton of literature over the years, and he's using it in facial aesthetics as well. Biological facial filler, which is
like the next generation PRP facial is like PRF, albumin, whatever.
Cool. And then he's also a periodontist, so he's a dental specialist by training. So he also is using like this dental side of like, how can we do different spins? How can we do this, that, or the other? And so I've learned a lot of that through him and his knowledge and reading his studies. It's interesting stuff.
And so
Yeah.
you have you're kind of pre-treating them. You're thinking about how like sort of to optimize the tissue bed as best you can. You talked about hyperbarics. You talked about IVs, and I guess IVs you mean like nutritional IVs is what you're talking about here, or
Yep.
optimizing their nutrition and
Yep.
cellular health, that kind of thing.
For sure. Yep.
Gotcha. And then from there, you have like sort of the in or perioperative or intraoperative work that you're doing with everything you just mentioned. And then sort of post-operative, is there additional things that you're typically doing too? Pardon the interruption. This episode is brought to you by Transcriptions, makers of precision-dosed, physician-formulated, and pharmaceutical-grade formulas in the form of a buccal troche. For this episode, check out our Tro-Z. This is our comprehensive sleep formula. It has 8 different ingredients, all optimizing sleep from helping you fall asleep to stay asleep and waking up feeling rested. It has things that are working on the GABA system, Hanakyle and Agrin. It has things working on the other systems like 5-HTP and melatonin, that melatonin so important for sleep, CBN and CBD working on the endocannabinoid system, cordycepin, which is increasing your deep sleep. Check it out at transcriptions.com. Save 10% on your order by using code POD10 at checkout. Now back to the show.
Yeah. So we're doing the same kind of handful of steps. We're doing more laser therapies the day or two after, more hyperbarics. And then it's kind of patient to patient,
Sure.
did we deal with metals in any way? What was their inflammatory response like? How does that nutrition look like, before and after? Obviously that's a big deal.
Yeah.
So I think it goes back to, it's much more than your typical dental approach of like, go fill a bill, what people know.
Yeah.
But it is a commitment on people's time. I mean, these things take time. It takes us, but we see really cool results.
Yeah.
It's really great to be a part of it and kind of being a maverick in the space. But thanks to people like you, I can learn things like hyperbaric. Like, oh man, that would help like huge. Like, how can I incorporate this? So it's an ever learning process of
Indeed. Yeah, I mean, if we stayed the same, it'd be boring, right? So you always got to think about, how we can, optimize.
Got its sleepless nights here and there, but all good.
Not just from the kids. Yeah, I was about to say. Well, you talked about metals. I think that's the next comment or the whole sort of bucket of things. So you said earlier that, metals shouldn't be in your mouth. So talk about why metals have been our mouths classically, and then what are you doing to get them the hell out at this point?
So metals are kind of like that. They're a material of old, I'll say. I'm lucky to be in the world now where we don't need that anymore. I don't think. But they've been used for decades, centuries in dentistry. The one that stands out as arguably the worst one, in my opinion, would be amalgam. Amalgam is what everyone's called their silver filling material. It's a little bit of a misnomer. It's actually about 50% mercury by weight. So it's more mercury than it is silver. And what we know is that releases a mercury vapor 24/7. And that can make a patient sick, affect their systemic health in a big way. Dentistry for a long time, I think, has just assumed that they're safe. Anytime somebody says something is safe and effective, I usually will pause for thought and say, if you have to keep telling me that, I'm going to question it.
Sure. Especially recently. I guess
that's what I questioned early on, maybe. And as I dove in and found a lot of research to say, hey, of course these things aren't good. We've known this since, at least the 80s from the VIMI studies. There's some studies then were fabulous studies. So it's not a new piece of information, but I think dentists get lulled into like, oh, we've used it for forever. It can't be that bad. Everybody would be dying. And it's like, well, that's not really the concept here. It's more of a chronic issue, not an acute technically.
Right. Not the Mad Hatter style, but more the chronic low grade nasty.
And I think, again, I hate to say logic, but I think a lot of patients know this. And it's not rocket science. If we have to have these like separators on our buildings that when we remove mercury and it can't go into the water systems, so it's toxic when it comes out, it's unsafe when it comes out, you have to mix it in, it's unsafe when it goes in, but then it's safe when it's in there. That was like wait a second kind of moment of mine.
Yeah. Were you saying that there was studies in the 80s that showed that these fillings were causing problems? Yeah.
So the VIMI studies were early on. There were sheep studies, and then I think he repeated them on later in monkey studies. But basically what he showed is they would radiographically mark mercury in an amalgam, place it in a sheep, and then I can never remember if it was like 60 or 90 days later, they sacrificed the sheep, and then they can trace where it went. And they found it all over. Of course, the GI system, the brain, liver and kidneys, detox, organs. And so that was early on, and no one like kind of everyone just kind of poo-pooed it because that was a main filling material of the day. We didn't have as good of what we have now, I'll put it that way.
Right.
But I mean, when you go into the literature, and I would say the IAOMT, who I'm a big proponent of, the International Academy of Oral Medicine and Toxicology, it's a long one. They have all the studies on their website, and it's fascinating. And that's where my career kind of started. I had started to delve in with them, and there's all kinds of studies to show it. And then now, I mean, I think we've passed that, where just like fluoride, we'll touch on that in a second, but we've kind of won that battle. The European Union, as of January 1st of this year, banned it. It's been banned in multiple countries for
That's amazing. Okay.
years. Yeah. So it's like, I think in the US, we're maybe a little bit more ignorant, or maybe just like we're sue happy. So we'll just quietly maybe phase it away, I think is maybe the approach that we take, but it's definitely not a good thing. And we don't use it. And, and I think from a mechanical standpoint, I'll say this too about amalgam. Early on, I would see, before I thought amalgam was, unsafe for people, I typically would see it cracking teeth all the time. It was breaking teeth. And when you looked at an amalgam up close on a tooth, you'd see cracks with it, kind of like cracks in a door jamb. There's a stress point. And as I dug into amalgam, it's extremely hard material. And when you put a really hard material in the center of something that typically has a little bit of flex or give, it has like a wedging effect, kind of like an axe head in a stump. So I would see it cracking teeth and breaking teeth. So from a structural standpoint, I thought it was just a terrible material at all, and to begin with. A lot of dentists use it still, I think, because it's super cheap. It's subsidized by a lot of insurance companies, and you don't have to try hard. I'll put it that way. When you place it, like it would be wet, sloppy. You don't even have to look. You just kind of slam it in the hole, carve it up a little bit, and it's good. When you place a nicer, white filling, it needs to be clean and dry. You have to take time. You got to slow down, do a good job, bond well. So I think there's some nuances there where.
Oh, I see. It takes a little bit more of the art of working with the tooth a little bit more.
Yes, it does. Yeah.
I mean, look, we know that our FDA is much more lax compared to other countries, and that's, hopefully something that might change over the next couple of years. We'll see as far as how that goes. But that's awesome about the EU and mercury fillings. I mean, what are your options now as far as non-amalgam fillings? What do you typically use in practice now to fill teeth?
Yeah, so for a routine filling, it's what's called a composite resin. And since BPA-free ones exist, I usually elect to use more of a BPA-free one.
Oh, nice. Okay.
Yeah, and they work just as well, so I kind of think, why not?
Is composite like a plastic then, or what is composite?
Kind of like it's like a bis GMA, and some of them have ceramic particles kind of impregnated in it for strength.
Okay.
Another main one that we use a lot is just different types of ceramics. So that work really well. And if there are ways to test if somebody's immune system would react to some of those things. Of course, metals as a Melisa, I feel is a gold standard. And we can talk about that too with the metal topic. But as far as the ones that people use, are usually composites or ceramics. And there are ways to test, your serum, your immunological properties to some of those materials to see if they work for you or not too. So. Is
that something that you would routinely do? I mean, or is that something that you don't typically do unless it's something that you have like a sicker patient and you're just kind of worried about causing an immune reaction?
Yeah. We typically have most of the things we use are clean anyway. That's just the style that we kind of exist in.
Right. Sure.
And so, but if somebody wants to be tested, or if I have a really sick patient, I'm like, hey, your system's triggered to everything. Yeah, I think it's triggered by me just sitting here. So let's maybe it's a good idea to check. I don't want to use something that otherwise could be harmful.
No, understood. And so you're talking about this test to test for metals as well. Like what test was that?
Yeah, so the Melisa test. The hard part about the Melisa is we have to ship it over to overseas, so it can be kind of a pain there. But it is possible, and for anybody that's listening, it is possible to check your system against a lot of metals used in dentistry, because it's not metals in dentistry are never a pure metal. Shouldn't say never. Extremely rarely are they a pure metal. It's always an alloy. Amalgam is an alloy.
Right.
When we use a
conglomeration of metals together is what you mean.
Correct. Right? Yeah. Yep. Yeah. So metal implants. I'm not a big fan of metal implants. And those are typically a combination of that's another hot button topic. Usually a combination of different metals, and you can test yourself, against some of these metals. It is possible.
And so they just test for like the immune reaction using
Yeah.
maybe your white blood cells or something like that. And
Yeah.
it's a test.
Typically,
Okay.
it's like a type 4 response. Yeah.
Gotcha.
Delayed
Interesting.
response type of thing.
Like
Yeah.
okay, that makes sense. So when you're thinking about taking metals out of somebody's mouth because maybe they have systemic symptoms or they don't and they just want to take them out, there's got to be a very specific procedure on how you do this, right? Maybe you can run us through a little bit what that looks like overall.
Yeah. Yeah. So when you remove metals, you want to be as safe as possible. So this is a little bit where my journey started as well. If you just go in, like if you'd like to have your metals removed, I would vet maybe your local dentist or the IAOMT has a really nice directory of people that have been trained to do it appropriately. But basically, if you just go in and start kind of drilling them away, you will create a massive exposure to that patient. They'll swallow a bunch of it, and maybe not the safest thing ever. And not maybe, it's not safe. So,
Yeah.
so
Doesn't sound good. Yeah.
no, so typically you'll follow what's called the SMART protocol. So a safe mercury amalgam removal technique. It's basically a multiple ways of diminishing your exposure. So rubber dam, a certain type of suction that sits by the mouth that will take up a very high percentage of the vapors that are coming off, like those type of things. The person needs to be draped. And it's also for the dentist too. So like
Yeah, that's what I was thinking.
it's a two-way street.
Yeah,
and I
totally.
thought, gosh, I have at the time when I got into this, I had one child, and then I have a second on the way. And I was like, gosh, I want to be around
Right, totally.
in a physical and mental capacity. And with mercury's being very hard on the neurological tissues in the brain,
Yeah,
if I'm going to remove this all day, I want to be as safe as I can for myself and my staff too.
totally.
God forbid they're carrying, baby, or they have something too. Of course, we want to be safe for everyone. So it's important to do a technique appropriately to remove all those things safely. We treat all metals the same, whether it's amalgam or metal from a crown or something like that. Yeah.
Got it. And what are some of the things that you found to be really sort of the game changing? It sounds like there's a SMART protocol that it's been pretty well established. Have you found any other sort of tools and tricks that you use in the office or some of the other biological dentists that you work with do that are kind of next level or that you're working on?
Yeah. So even when people have metals removed, we still will have IV therapy if they want it. We'll still, it's still kind of that, how can we surround the patient as many things as we can to protect them, but also increase their response in a positive way. We do those type of things. We do more laser type stuff as well, and a photobiomodulation style of stuff.
Nice.
And then I think what's really helped patients a lot for us is we brought on what's called CAD CAM. So it's computer aided design and computer aided manufacture. What that means in layman's terms is basically once we remove a metal, let's say we remove a cap, we can make you a new one that day, made on a computer, made out of a machine, out of a ceramic, and put it in, and you're done. So you don't have to leave, come back in 2 weeks.
Got it.
A lot of our patients travel a long ways. A fair amount of them fly in. So they don't have time to be flying 4, 5, 6, 7 times. And so when you bring in technology like that, which a lot of dentists that don't do biological dentistry have as well, but that can be really nice for patients, and you can utilize materials that again aren't going to tread on their system.
Yeah. So it's kind of like a 3D scan, like a 3D printed kind of ceramic.
You can 3D print some, and then other ones are like a ceramic block that it will like kind of mill it out of, kind of mill the new tooth. Yeah.
Nice. I feel like, in general, dentists have always had really cool toys compared to everybody else, right?
They're crazy expensive, but they're really crazy when they work. Yeah.
Yeah. I can't imagine how much these kinds of devices actually cost. You don't have to tell me, but I that's the other thing. I know that like going to dental offices, like just sort of standard dental offices to stay on top of the technology, they're spending, hundreds of thousands of dollars sometimes a year just to stay up on that. It sounds like it's not a small endeavor to subsidize, all the technology that's going into your practice. So.
I feel for dentists, and we've started to train dentists and train their staff almost as much in the biologic stuff as much as kind of like a little bit of mindset stuff, because dentistry is difficult. It's not an easy thing to do, even though dentists want to say it is. It's not easy no one likes to go to you. People like to come to us since it's like more of a health focus, but
you guys are a little different.
Like to go to you.
Yeah.
And it gets hard, like to try to keep up with technology costs a lot of money. If you're in insurance, they're really kind of cutting you at the knees everywhere they can, or they'll only pay for things, in my opinion, that are never in the best interest of the patient. And then you have the organizations that you are a part of, which I'm usually not a part of any of the normal ones because I disagree with their messaging, what they're about. But those organizations, are throwing money at the insurance companies, but that's not in the patient's. But it's just, it's rough.
Yeah.
And so dentists I feel for dentists, and it can be burnout quick, and you want to do the best you can for a patient, but you don't have the time. And
Yeah.
it's hard. It's hard.
This, and this,
Medicine's the same way.
yeah, I was about to say this reflects on all medical specialties and almost all professional specialties where you have a service orientation and you're involved in the insurance world in some degree. You're not really able to do what you'd like to do all the time. Is you're kind of stuck in that model. So it's nice to be out of that as you are, but it comes with being in the sort of forefront of things and changing things as you go, and having to stay up late sometimes and figure out what to do next. One thing I wanted to ask you as well is around cavitations and wisdom teeth, because this is another one where there's a lot of questions overall, as far as, why are we getting the wisdom teeth taken out? Should we be getting wisdom teeth taken out? What are cavitations? I know that cavitations can be very common. So maybe describe a little bit about that ecosystem and what's going on there.
Yeah. So cavitations is also a hot button topic. And currently I'm in a program in Boston with a few, I would say, kind of top tier dentists. And we are training on cavitations through a major university.
Okay.
So for dentists out there that have maybe been a little bit scared about cavitations, we're at the point where we have published literature on it. It is wild. It's out there. It's very forward with it. And we're being trained in a university setting on cavitation. So there's nothing to be scared of, I don't think, anymore.
What are they? Tell me about them.
So cavitation can develop, technically, I'll call it a disturbance in the jawbone.
Okay.
And it develops after a tooth is removed. It can be any tooth, but the most commonly I would say removed would be the wisdom teeth, right? Those third molars. And we can kind of circle back to like, why would we have them if they need to be removed, right? But when you remove a tooth, I think what we've thought for years, for decades, is that the jawbones heal just like any other bone, but they don't. The process is a little bit different. And that's what we're learning kind of in updated studies. Mm-hmm. So what I kind of like to say is the bone will heal, the gum will heal over the top, the bone will heal over the top, but inside where the marrow space is, you get a major kind of an immune derailment.
Okay.
You get a cytokine profile in there that is very low in pain. So they're typically asymptomatic. If they're symptomatic, they're called something else. It's kind of called a NICO, but typically there's no pain with them. And you have to spot them basically on CBCTs is the best way. We're working with some other ways to spot them. I think that'll be coming in the next year or two. But you get a really high level of some majorly pro-inflammatory cytokines that are stuck on indefinitely. And the research has gotten pretty forward with like, hey, when you have these inside your jawbone, these can drive systemic issues for patients, whether it's autoimmune disease, chronic inflammatory patterns, those type of things. So they need to be remediated. And the remediation process is a little bit the way that we do it, and I think the way that it should be done. I'm biased in the way that we do it, of course, but you open those sites, you clean them really well. I spent an hour in one this week, just cleaning. And then that's the same, ozone, lasers, PRF. Sometimes a type of grafting of a bone can be needed depending on the defect. That's a whole thing that we're kind of learning in real time now. But basically, you clean them out, and people get better. My mom, that's her story. That's kind of some issues that she was having that were, quote unquote, undiagnosed in a sense that went away. And so when you just remove the burden off of people, like their body will heal. Yeah. But it can be definitely a big rock in people's shoe. And a lot of dentists, I'm hoping by the end of my career, not only have we trained some dentists, but it's readily accepted that what we're doing, like how we need to change and improve for our patients, because there's a lot of sick people that need help.
So do these cavitations tend to progress over time, or do they tend to kind of stay the way they are and can just still cause problems in that capacity? Or do you see them, because they're into the bone itself, it sounds like, do you see them sort of migrate, progress, get larger, that kind of thing as people get older, or is it that they're there longer, or not typically?
No, I can't say that we've seen that. I just signed up our clinic to be, part of a group where we're just continuing to study them. We know a lot about them, but like, I feel like the more that you learn, I'm sure you would agree, the more that we realize we don't know. And it's a burden that we want to carry to try to improve throughout our career. Like, how can we be better? How can we learn more? How can we apply that to patient care? I don't think that we have anything to show that they progress per se.
Got it. But they can just remain in that area and still
Yeah.
cause significant issues.
Yeah.
And I guess maybe some of the stories would be cool. I mean, you don't have to speak to your mom specifically if you don't wish, but in the sense of what have you seen? Like once you start taking out these cavitations or removing them or closing them up and optimizing, and sometimes it sounds like it can take quite some time. Like what have you seen in patients or what have you seen reported like that has been pretty phenomenal to you?
For sure. Yeah. I mean, just anecdotally speaking, I can speak for my mom. So my mom had a root canal removed. She loves that I share her story.
Okay. Yeah.
And she's like one of our biggest fans. She's always like bopping around the office. So is my dad. So if anybody out there and ever comes and visits, if you see this goofy guy walking around, I need to like kick him out. But he loves the hyperbaric so much that he's always here. It's like his home away from home. So I'm like, Dad, you can't like roam the halls all the time. So, he's like in our staff room, like, we have all these. My wife is very forward about stacking our staff snack area, like good, healthy stuff. So my dad's raiding our fridge. I'm like, Dad.
That's hysterical. He must be retired. Okay, but okay.
So we removed root canal for her and cleaned out her cavitations. And basically what she had going on ever since I was little, and it probably was before that, but I know I can say from when I was little that she had heart palpitations, flutters. I don't necessarily think they were anxiety type of thing, but like, she's a hard work. She was a nurse, so she had seen plenty of doctors.
Sure.
We're going to put her on a med. She didn't really feel like that was, she'd just get them a couple times a month at least, maybe once a week. Come on, pitter patter, go away. They went away completely about 48 hours after that was completed, and they have never been back. And I think we're at don't quote me on this, 6.
Okay.
So what do I see anecdotally? We've seen gut issues go from like IBS, horrible, daily to nothing after, and brought on by certain foods in some cases that they can then eat and have no problem.
Interesting. Yeah.
We've seen cardiovascular things, those heart issues, chronic high blood pressure, that type of thing. So people have been able to get off of some of those meds if they were on some. A lot of chronic fatigue and sleep things. I had one patient that was it was in the 20s, years on sleep medications, off them completely. And that's a life-changing thing for somebody. I mean, she's the most amazing human being ever. Yeah. And you feel much better about being a dentist and what you're doing, helping people have a quality of life back.
Yeah. And that's amazing, right? Because I think it's just so important to remind people that are listening and clinicians, like this is not people that had any symptoms in their mouth per se, right? They weren't coming in because they had pain in those cavitations. We said cavitations are usually painless, or their root canal usually is also painless as well. Although those can cause symptoms, I guess, maybe more so. But that's been the case for what you're describing here. These patients didn't come in with mouth pain and then they got the cavitations removed and their sleep got better. It sounds like they came in because they had issues systemically and they were looking at the mouth as maybe, being the sort of nidus for some of those issues.
Yeah.
Right?
Yeah. And I think that's kind of one of the overarching things that we never know what's going to happen for somebody. So we never can promise anything. And that goes for, I think, medicine in general. Yeah. And I have very frank discussions with every patient when about that. We never know. And I think that's where maybe some of our efforts and studies needs to be. But I also think, and I'm sure you would agree, the human body is so dynamic that it's hard to just study A causes B to be C and be done.
Of course.
There's so many things at play. And you're talking about a pro-inflammatory cytokine storm in a sense, right?
Yeah.
That can have a lot of different effects on people. And so, it's interesting. I think we need to learn more, but that's what we're seeing in time right now.
So this, what reminds me a little bit of, as I was kind of thinking about it, is that we talked about the wisdom teeth. Right? We talked about taking those out. Like, I guess this kind of reminds me of like the children thing for a little bit, because obviously you have them, I have them. How are you thinking about dental care in children overall, especially maybe wisdom teeth would be one question there. Another would be, braces, retainers, which is like a car payment every month for each of my children. A nice car, like not just like, like a Prius. We're talking about like a Volvo 6-seater, all-wheel drive, all the things.
Arguably a plane.
Maybe, yeah. And so because I have 4, like 3 of my kids now are in braces, right? And one has a retainer. What is your sense of all this? I know that's a big question, but we can kind of go anywhere you'd like there.
Yeah. Let's start with one where it's like, why do people have wisdom teeth removed?
Yeah.
Right. Like that's a mean trick for God to play. If it's like, let's give you this extra set, but like, let's rip them all out just for fun. That's not okay. Like, that can't.
Yeah.
So to make a long like process studying and reading process for me short, basically what we've seen is I think Weston A. Price, a lot of people know who he is, but
Yes.
Nutrition,
Yeah.
Physical Degeneration and book, basically places that were untouched by, I'll say, the Industrial Revolution in a sense. They were eating foods that weren't softer, and these tribes that were untouched basically had all their teeth, including wisdom teeth. Their jaws were developed fully. The nutrition was obviously much better, and they had no cavities, by the way.
Yes.
So, like, I prey on like all cultural bad habits. Otherwise, I wouldn't have a job.
Right.
I guess
right.
I should be halfway thankful, but we're supposed to have them. We're supposed to have room for them. What's happened over the years is that whether it's processed foods, softer foods, there's a lot of things there. Sometimes women have a hard time breastfeeding. That helps develop the palate. There's a lot of things at play.
Right.
We don't have room for them in a lot of people. So then they're deemed to be, let's go ahead and remove them because they could harm the neighboring teeth. And although that's true to some extent, I think there's also cases where people don't need to have them removed. So I don't think it's like a one size fits all. I think dentistry is taking that approach a little bit, but there's pros and cons to that for sure. And now that we know that cavitations routinely develop, you can say, well, are we going to cause more harm than good, maybe long term? Mm-hmm. So we should have room for them. But to get into like that kind of feeds into the orthodontics, like the braces and things with children. My approach, just to cut to it, I think, and I don't do it, but I have a really good local orthodontist. I think you need to get in early and often. So 5, 6, 7, help that arch develop early on. Use their piggyback off of the growth so that the teeth come in approximately where they should or are meant to. Don't wait till, in my opinion, they're 12, 13, 14, and all their teeth come in crooked, and then say, let's grab these things and straighten them. Mm-hmm. I also am very adamant against extracting teeth for braces. I think that we should be past that nowadays. I think that's a crime in a sense, and that's happening all over the place as well. We should develop their arches to house the teeth that they're meant to have.
And what do you mean by developing their arches? Talk about that.
So that would be, in one word, expansion. So instead of like straightening things, braces are really good. And I'm a fan. The clear liner companies have come a long ways too. So I think when people can use, a clear liner, that would be like an Invisalign, Candid. There's a few, those work really well and they're metal free. So I like those as much as we can. But basically we can make teeth straight all day long. But if we don't remember that there's a joint there that plays into that role, and the biggest one, like the elephant in the room, is their airway. If you straighten teeth but pull things back, you impinge upon the space for the tongue, you almost guarantee that child an airway problem, which can manifest itself in multiple ways. My orthodontist here is a great guy. He showed me case after case after case of kids that were on ADHD meds, hyperactive, and it's really like they're overtired. Once he's expanded them and their airways more opened up and they're breathing through their nose, they get some myofunctional therapy, gone.
Wow.
So I think we need to be, that's where that camp should be going is how do we develop, how can we not have an impact on the airway, arguably improve it? And there's a lot of really cool people doing cool things there. Yeah.
That would be the expansion piece. Is the idea is opening up. So like sort of evolutionarily trying to get close to what our jaw would have been before we had soft food all the time.
And we have the skulls and things to like show it, improve it. We have the measurements. Like this stuff is not really new per se, I would say. But you're right. I mean, like that's our blueprint. Nature is our blueprint.
Indeed.
How do we get back to that as close as we can? I think that's always kind of the overarching goal.
Yeah, I had a really awesome myofascial therapist on the podcast about a month ago. She's down in Texas. Her name is Karindi Ong, O-N-G. She's fantastic. And so
they're so good.
Yeah, I mean, I was just blown away. We went through the mouth, we went through the nose, we went through like the airway, and she's actually going to be working with my daughter today, actually, interestingly enough.
Yeah.
That has the smaller mouth and has all the expanders and braces and all that kind of stuff. So
they're invaluable. I kind of feel like myofunctional therapists, they could serve a role on a dental staff a lot.
I would think so. Yeah. I mean, I'm actually kind of shocked that they don't as much. I know they work with a lot of, after speaking to her, I mean, I was just shocked that this was not something that was like standard in most
I know.
dental clinics.
That's as big of the impact it has, right? It's like, wait, why is this like hidden knowledge? This shouldn't be hidden. This should be on billboards. I mean,
I had no idea that my tongue should be like right here most of the time.
Yeah.
Like I was like, that's where your tongue's supposed to be. Oh, who knew, right? So
Yeah.
well, that's probably why I have periodontal stuff down here. Is my tongue's always down here instead of up here. Anyway, so I was blown away, and I think many people that are listening should definitely check out that episode. And if you have a myofunctional therapist in town, they're probably working with kids, but they could also likely be working with adults
for
as
sure.
well. Yeah.
Yeah.
One thing I wanted a funny story for you is that I was going down to do a podcast down in Texas with this guy. And I went to go visit. We meant to go say hello, and he had a big smile. His whole mouth was blue, right? So he had some of our methylene blue, and he had forgotten that he had gotten these temporary veneers. So they had plastic veneers all in his mouth. And so his entire mouth, all his veneers had turned blue. But he had done this What's that?
It stained all of his temporary.
Stained all of them, yeah. But so the question, that's my lead in here to say, like, there's these guys and ladies that are doing these entire facial things where they're taking out all of their teeth and putting it all ceramics, I think. Do you know what I'm talking about here? Like, is this something that people should do, or what's going on with that? Do you know?
Sure. Yeah. So yes and no. A lot of people, there's a lot of power in a smile, and there's a lot of things can happen when people aren't happy with the way they look. So I don't want to underestimate the power of, like, hey, when somebody says, I want to have some veneers, I want to have a broader, nicer smile. And we've gotten to the point where it's almost like a menu. Like, do you want your teeth more square, wide? Do you want them rounded? Like, you can pick anything. And with digital technology, it's wild. Like, it's kind of like, hey, do you want some celebrity's teeth? Yeah, okay, well, I could probably mock those up.
Wow.
It's wild.
Okay. That is wild. Okay. I didn't realize. Okay.
Yeah.
So that's more like the facial plastic or like facial aesthetic kind of thing, or the dental aesthetic, or yeah.
Kind of. Yeah. Yeah. It'd be dental aesthetics 101. Yeah.
It's not really being done for like a health reason. So it was really doing more for like an aesthetic reason then.
Typically. Yeah.
Okay.
But I think I kind of always kind of prided myself a little bit in, like, how can we have both? Because I'm never satisfied with, like, just like, I want to have both. I want to have my cake and eat it too if I can.
Sure.
There are ways to do, like, really uninvasive veneers. Sometimes no prepping at all. You don't even have to touch the teeth. In some cases, no one even has to get numb. You can literally just make, like, nice veneers. Now, there's a lot to that. What I'm saying is I think what dentists sometimes don't do is they don't explain to people, hey, what's the most least invasive way that we can get from point where you are to where you want to be? Because cutting your teeth down for crowns, whether it's one tooth or all of them, I'm not a fan of at all. At all. Yeah. And there's a lot of reasonings there, but basically to shave it down that much, it can be destructive. And it can set them up for more problems later. So it's like, how can we least invasively get to the where you want to go and be happy? Because there's power in that too.
Yes, I wasn't clear when I saw him if it was because he was doing it more from an aesthetic perspective or from what's supposedly a health perspective overall.
Yeah, because your bite plays a big role in your health as well. So the way your teeth come together. So you can correct those things sometimes with, like, veneers, and you kind of get two stones in one, right? You can make it look prettier and you can improve your bite. So there's ways.
Gotcha. Okay. So maybe
not blue.
Not blue. We're trying to
maybe wanted it, but, like, I don't.
Yeah. So I mean, if you have, I think there's the plastic veneers. Those are always going to turn blue if you have any methylene blue in your mouth. But if you get, I guess the porcelain veneers is a different type of veneer, right? Or is there a different?
Yes.
Okay.
Yeah. Yep.
And those would be fine with any blue overall.
Typically, yeah. I mean, as far as I know.
Yeah. One question. So maybe like the last topic we can talk about here is oral health in general. I think that many of us have different ideas of what this means. Some people use things like Listerine and mouthwash, which they should not be doing. Other people are using fluoride containing toothpaste, and others are not. So I think maybe we can go over how you think about oral health, how you do it with your family, how you do it yourself, how you talk to your patients about it. Maybe the inroad there is maybe the fluoride question. So go for it. What do you think?
Yeah. So I look at the mouth as a gateway to the body for sure. But I also kind of look at it from a standpoint of, it's kind of like a garden. It needs to be nurtured and taken care of, just like the rest of your body. The mouth has an oral microbiome, lots of bacteria. Being a superhero kid or like a cops and robbers kid, I look at it as there's cops and criminals. The criminals are the bad bacteria, the bad things that will cause gum disease and problems. The cops are the more aerobic, the good bugs. You want those, right? We have more bacteria arguably than we have human cells on us, right? I mean, that's.
I heard that. I think that this is the second most microbiota compared to our small or large intestine. Is that right?
Yeah, it's super diverse. You're correct. Yep, exactly. So there's a lot of power in that. And I think that's where you start to get into like, how do I take care of a patient, or how does a patient take care of themselves with like, what am I at risk for? And so there's really good oral microbiome tests out there now that can map the entire oral microbiome. And then with that information, you know what you're battling against. And then you can say, I should use these products. I should do this for 2 weeks and then switch to a maintenance phase with this product.
So it's actionable enough now where you can actually get enough information from an oral microbiome test. What are some, I mean, we can talk about maybe some of the names you use just so I get a sense of those. What are some of the testing you use?
Yeah, the best one out there, in my very strong opinion, would be one called Bristle, like a toothbrush bristle.
Yeah, I've heard it. Yep.
Yeah. For the record, I don't get any kickbacks from them, but I know the guys, they're amazing. I've done a podcast with them. It's a great product. We use it for a lot of our patients. And basically, once you map the microbiome, not only can you tell, like, am I at risk for cavities and gum disease and bad breath, the typical things, but you can also start looking at systemic correlations, like, am I at risk for some gut issues? And I've seen that in plenty of patients. Like, they're having a SIBO or an IBS or some sort of gut disturbance they can't get over. They've changed their diet, they've done all the things. And at least part of that story for them is that their mouth is housing a lot of bacteria that cause that. So every swallow, whether it's food or just saliva, is billions of those things going down the hatch. Typically, a lot of them can tolerate the stomach acid, or people don't have enough stomach acid. You know, their pH is too high, so it can slip through. And that's contributing. So I feel like it's our job then to kind of pinpoint those and correct them. But I think that's one good step for a lot of people. I'm not a fan of fluoride.
Why? Tell me.
That battle is almost 1-2. I mean, you might see states banning it in the water. So are you going to die from using fluoridated toothpaste? No, you're not. But what we see in the literature is we have a chronic overexposure to fluoride if it's in our water systems, which, mind you, what's being put in the water systems typically is not legal to put in other water areas, right? That's a pause for thought moment. I always thought, if it's illegal to dispose of it in the ocean, well, then why the heck is it able to be put in our water system?
Yeah.
And the literature is pretty forward on, like, hey, these chronic exposures not only are associated with lower IQs in children, but also have major implications on the thyroid, bone. And so, and then lastly, the way I wrap up that one is basically, like, fluoride doesn't really serve any sort of biological function in a sense. It's definitely not a tooth vitamin. Something I used to say also. I'm guilty.
Used to say. Nice.
It's not a tooth vitamin at all. And so, you know, we can be more forward with, like, hey, why are you getting cavities in the first place? It's not a lack of fluoride. Never has been, never will be.
Right.
Where's your nutrition? Where's your stomach, pH? Where's your digestion at? Are you actually, taking care of your mouth? How can we help you do that better? Usually it's a pH issue. There's a lot of things that could be, but it's definitely not a lack of fluoride. So coming at those things with more of a root cause approach, that's a fancy term nowadays that people like to use, but it's true. What's causing that?
Yeah.
And how can we switch it?
I have a funny story about that. I was in a lake in Bolivia called Lake Titicaca, which is kind of a funny name for a lake.
Yeah, it is.
But it's one of the highest elevation lakes in the world, and there's still indigenous people who live on some of the islands in the lake, in and around the lake. And evidently the lake has a very high quantity of fluoride in the water. And so you go to some of these areas, and obviously the people are very dark skinned, but their teeth are like bright ass white because there is so much fluoride in the actual lake. I just kind of thought that was kind of a funny story.
Yeah.
But certainly I like that you've transitioned to calling it a mouth vitamin, to having no real physiologic or benefit for our teeth overall, because if we're doing the right things, it shouldn't be necessary, right?
Right. And those people probably had fluorosis. There's so much fluoride that it was making their teeth more brittle in a sense, right?
Probably.
Yeah.
Yeah,
So
probably. Yeah.
I think that battle's been won. A dentist, it's like it's a golden calf. Like, we worship fluoride so bad, and it's hard for them to let go of it because we've been trained so heavily in that.
It's a hot button issue too, right? I mean, I was talking to an older dentist, or actually a guy that was involved in the dental side of like the sort of business side of dentistry, and he got all these regulations actually passed back many years ago about fluoride. And like, he was so adamant that fluoride needed to be in everything. I was like, there's no conversation to be had with him.
No,
But I think, as you said, now more states, more counties, people are taking fluoride out of the water. You think we're going to continue to see that, and you're happy about that, I'm guessing, right? So
I'm very happy about that. Yeah. And I think to wrap that conversation up simply would be the things that make you healthier in general, like a good diet, exercise, proper sleep. I was just reading some studies a few weeks ago on melatonin and its role in preventing cavities. And so like,
Interesting. Yeah.
just like things like that, the things that are going to make you healthy overall are going to help your mouth be healthy as well.
Understood.
You know, so
Yeah.
yeah.
Yeah. And so you were talking about the oral microbiome. And so what is your sense on mouthwash in general? Is there any
Yeah. Oh, yeah.
reason
You said
at
that.
all? I'm going to ask about mouthwash. I'm going to ask about flossing, tongue scraping, all
Yeah.
these things, because these are the things that,
All of them are great. I don't want to say any of them are like, oh, you don't need to floss. Like those are all good things. Like we need to clean those things up. There's a biofilm in there that needs to be, but mouthwash is, I'm not a big fan of mouthwash. I guess it depends the style of mouthwash. That's what I really should say.
Okay.
If you go down your Target aisle and you have mouthwashes of every color under the rainbow, that should be like what's in these things to make them all colored, first of all.
Right.
A lot of them have fluoride in them as well.
Mm-hmm.
And what you see is it's like dropping a nuke bomb on the microbiome. They're killing all the good too. And that's not good. It's kind of like trying to sterilize the mouth, which you can't do. And it's not good. You throw that microbiome into a disarray, and usually the bad will win over the good, when it's trying to come back around. There are some good mouthwashes out there that have no like chemicals in them per se. They're more focused on alkalizing the mouth or keeping a more neutral pH with some like bioavailable calcium and xylitol, those types of things. Those are great. So I think it depends on the mouthwash, but by and large, not a fan. And one of our new patient things is we test like the nitric oxide, with a saliva pool. And typically if people have low, that's an indicator that they don't have a lot of the good bacteria, because those are typically producing some of that and converting that process. So I'm not a fan of mouthwashes in general, but people like it because it's like, it feels better. You know, sometimes they burn, sometimes they don't. It feels clean. And it's like, no, that thing's just carpet bombed. Like, don't do it. Yeah.
So is there a difference? So I know that there's some interest in what's called oil pulling. What is oil pulling? And is this something you recommend?
Yeah. So the first time I heard of oil pulling, again, going back to kind of what I said before, I'm usually a person that's like, okay, well, what is it? Is there any literature on it? Like, it sounds a little bit kind of goofy. This was early on, but I'm like, I'm open to learning anything and changing if I feel I need to. Mm-hmm. It's part of that pioneer process. I found multiple studies on oil pulling showing that it helped every parameter as far as like gum bleeding, a lot of these things that we look at in as far as health and dentistry as practitioners. So I think last time I had, it's like 7 or 10 studies showing how positive it was. And it's kind of like it's an Ayurvedic practice. It's like they used to do these things and we think, those people are nuts. They don't know what they're doing. And it's like, no, actually, once we study it, we find out they actually were probably onto something.
Yes.
I am a fan of it. Coconut oil is the one I usually gravitate towards for the most part, or an ozonated olive oil can be really beneficial. That's a great one.
And so the idea with pulling is that you're just kind of swishing it in your mouth and you're kind of just letting it hang out there for a period of time, right?
Exactly. You're swishing. Some people say do it for 20 minutes. I've tried it. That's like brutal. No one can do that.
Yeah.
So the hack I've developed for our patients is you to get those silicone ice cube trays.
Yeah.
Small little ones, small cubes, melt coconut oil, a higher saturated fat, right? So it'll set up basically. You can put basically in those cube trays, and then once they set up, you just pop them into like a mason jar, put it in your bathroom, and then it's like a single serve. It's quick and easy, and it's part of a routine, and then you'll do it.
Got it. So you don't even have to freeze them, right? It's just putting them into the single serve, because it's going to, obviously, if it's a saturated fat, it's going to be hard at room temperature, just for people that are listening. So you don't have to like put it in your freezer or anything like that.
Yeah, no. I haven't tried that, but I wouldn't do that.
I don't think it's necessary, probably. And then it just kind of melts in your mouth as you're doing it, kind of thing, right? So, yeah. What about tongue scraping? Are you somebody who recommends that?
I am. Yep. The big one there is that's a big one for breath. So if people struggle with bad breath, that's a good place to start. A lot of the bacteria that hang out in the pits and crypts and these little spaces in your tongue, they create what's called VSCs, which are volatile sulfur compounds. Sulfur, we all know, sulfur hot springs, those things doesn't smell very well. Yeah. So that's a good practice to implement, especially with people that struggle with bad breath, for sure.
Got it. Okay. So flossing.
Yes. I am a fan. I know. And I know, like, we can usually tell if you just did it like the day before when you come in. Like, but it's also a pain in the butt. I get it. Like, I'm human. Yeah. There are I don't have any affiliations with any of the companies, but there are like they're like handheld little flossers that are, I think Slate is one of them. There's a few that I want to go out and try myself, but
Okay.
that make it a lot easier and more beneficial for
Gotcha.
patients. Like, again, it's establishing a routine and then you can stick with it. It's
Gotcha.
the hard part.
Understood. And then I know most of the floss are plastic, right? So there's probably other better ones than plastic to be using for floss, I would imagine, right?
There are. Yeah. And there's some of them are, they'll have like those forever chemicals in them, things like
Yeah.
that. So just
Yeah.
like anything else, be cautious, kind of
Yeah.
vet your things a little
Yeah.
bit. Yeah.
Yeah. Maybe one more question about this, and then I want to wrap up with you. But you talked about checking the oral microbiome and then being able to sort of direct your therapies. What are you using? Are you using oral microbiome optimizers now? Like, and what are those? Are you using, I know there's a couple different sprays out there now, and I've seen, what have you found to be helpful, or what are you interested in this capacity?
Yeah. So, when we test the microbiome, again, like you said, it's objective, right? And
Right.
I think I learned like, what's an example? I like to monitor my sleep. A lot of us do, right? And when you know an objective data
Yes.
set,
Yeah.
then you can make decisions. But a data set that can't drive a change in behavior, or at least a decision for a change in behavior, is kind of like a pointless data set.
Right.
So that's how I view the microbiome, as like, I want to know what you're at risk for, but it would be a little bit more of a waste if I didn't know what to do with it. So Bristol's reports are actually really nice. So it's a decentralized healthcare test. You can go do it yourself. You can get on the website. You can order one, they'll send it to your house. You send it back.
Nice.
Most likely, your dentist may not know what to do with the report afterwards, because a lot of microbiomes maybe not something that every dentist is looking into.
Right.
But the report is like as simple or complex as you want it to be. So for the engineering people it's just kind of a red stoplight or a red, green, yellow stoplight system. And with that data set, it'll say, we think you'd be beneficial of, using this type of mouth rinse and then this type of toothpaste afterwards, that type of thing.
Got it.
That's what we've seen. And I once I can physically get eyes on the patient, sometimes I might tweak a few things. Like I'll go away from their recommendations depending on what I'm seeing clinically for a patient.
Sure.
But we live in a world now where there's a lot of options, and there's a lot of good options. The days of going to your local store and getting Tom's of Maine, who I think is owned by a big corp now anyway.
It is. Yeah, it is.
Yeah. Are over, because people can label read. And also, like, Tom's of Maine is a classic one, but like a lot of times it didn't have anything to help you. It took out the fluoride, but that was their marketing advantage.
That was it. Yeah.
So we have a lot of options now where there's good products out there that people can use to benefit.
What are the main things in toothpaste that you're trying to have people avoid in general? Like, as far as different products that are in the toothpaste itself, obviously fluoride is number one. What are the other ones that people should look to avoid in their mouth overall?
Yeah. So there's a few different things. Fluoride's the biggest one. Anytime you see a long list of things that you can't really pronounce, be cautious.
Yes.
That type of thing. Triclosan's another big one. Some of these color additives and things, titanium dioxide, or like E171's a whiting
agent.
Coloring agent, which is interesting because dental implants are titanium. So there's a pause for thought moment, and that's been banned, I think, in France. So I read your labels, kind of look for things, that type of thing. But what I like to see is, I do like hydroxyapatite. Okay. There's a little bit of, scare debate on that out there, but I think if you're reading the literature appropriately, you're finding that the right type of hydroxyapatite can be really beneficial. Okay. Another one I really like, if we're going to name a few brands, Elementa is one that doesn't have hydroxyapatite, but a lot of bioavailable calcium, xylitol. It's based on pH. It's a really fabulous product and really simple. That's a great one too. So
yeah, I appreciate that. Well, cool, man. This has been great. I have one question for you. This has been a nice little tour de force on biological dentistry, just kind of like dipping our toes in all the sort of nuances of what you do, and just kind of trying to give like a potpourri of biological dentistry today. But the question I ask at the end of every one of our podcasts is a more general one. The name of the podcast is called the Smarter, Not Harder podcast. And so we ask all of our guests at the end, what are 3 ways that you live, or that you can recommend other people live smarter, not harder? And of course, this can be all about the teeth if you want. This could be about your personal life, your professional life. TMI is okay too. I'm just kidding, whatever you want to talk about. But it's completely up to you. So what are 3 things that you can think of that might be good recommendations to live smarter, not harder from your perspective, Cody?
Sure. First one would be, of course, I'm biased, but I would say health starts in the mouth. So I think just take the mouth serious. It's not what we always maybe were told it was. And hopefully we've given some info today for some people to take some steps there. Second, I would say would be, don't get so caught up in the fear-based stuff. Like, do what you can with what you have and let the cards fall. My wife has been really good about that. Like, you get so torn because, we live in a world where we have carnivore and we have vegan. It's like, it's like just no one can be right anymore.
Sure.
And so
sure.
just, I think having that simplicity, maybe that's the term I should start with. Number 2 is simplicity. Just keep it simple. Otherwise, It's hard to establish habits that will stick. And then I think lastly for me has been balance. Whether that's a big term, I just internalized that one. Whether it's work-life balance, whether it's balance on my plate when I'm eating. You helped me balance my cold plunge and sauna. I was maybe a little bit more forward with one than the other. We had a conversation about that.
Yeah, that's right.
Balance is good. Relationship balance. I think that's one that's always stuck with me as far as like in a world where it's all kind of crazy, like point 2, get into the balance and just hover in the middle. And I think most things, that's where people will find the most truth, the most respect, and the most benefit.
I love that, man. So thank you. So Cody, where can people find out more about you? Where is your clinic? I know people are coming from all over the world to come see you there in Iowa with the 5 other people that live there. Just kidding. I know 3 of them.
We're at like 10 now. So
we're up to 10.
Easy.
Okay,
we're up.
Perfect.
Yeah, we're
and corn. Lots of corn.
Yeah.
Lots of corn.
Yeah, for better or
So
worse.
where are you? Where can people find you, man?
Yeah. So we are right near Iowa City, Iowa. The best way is at our website, Vios. Vios is the name of my clinic, so Vios Dental. You can find us there. That'll give you a good idea of who we are and what we're about, and the therapies and the things that we approach with dentistry. I'm on Instagram, Cody Kriegel DDS, and a lot of dentists reach out there, but that's basically a spattering of who I am and dentistry. It's a mixture. Our office has an Instagram handle as well. And then my wife just started this new thing called the Dental Assistant Collective, where we're trying to train not only dentists, but like their teams.
Awesome.
And they're important. And
Huge.
they're also beacons of health for people. So, you can find us on all those social platforms and stuff like that. And at any point, I'm willing to talk with people and try to and it's one person at a time. We can improve the world quickly.
Yeah, and you've helped with some of my patients over the last couple of years, so I appreciate that as well, absolutely. Man. So thanks so much for being here, Cody. Everybody listening, check out Cody's website. Go over and check him out in Iowa if you need some dental work. And we'll catch you next time, man. Have a great day. Enjoy.
Thank you, Scott.
Thanks so much for tuning in to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. And I learned a ton during this podcast. Biological dentistry is such a cool field. It's being pioneered right now by people like Cody and like others around the world. Dr. Dom Nishwitz, who also is a good friend of mine and will be on the podcast at some point. And so you learn about biological dentistry, ceramics, titanium, metals, cavitations, oral hygiene, what to do in children, so much more. And I learned a lot. I hope you all did too. So if you did, don't forget to like and subscribe below so you never miss an episode. And we'll see you next time on the Smarter Not Harder podcast.